Yeah.
Is it visible?
Yes, it is visible, sir. Would you like to move a slide or two?
Okay.
Yeah. Yeah,
Yeah.
I think we are fine. So we are going to introduce you first and then we request
Yeah,
to come
yeah,
on
yeah.
board.
That I think more people will join. Shall we wait for them or?
So
Uh, I,
we can close the presentation. Samiksha and Parul will introduce you, and then we will ask you to. They will ask you to move. So as of now, sir, if you can just close your slide, that will be good, sir.
I'll stop sharing, no?
Yes,
yes,
sir. Please.
Okay.
Thank you, sir.
thank
Yeah.
you.
Thank पारुल हम लोग 6-5 को स्टार्ट कर सकते हैं. उसके बाद people will join as and when I think. नहीं.
Yeah.
आपके और मेरे 6-5 में कितना अंतर है बताइएगा.
आप सिस्टम में देखिए, मैं सिस्टम टाइम बोल रही थी.
9:84.
6-4 here.
हाँ.
Yeah, same here. Our clock is on time. It's in sync. Doesn't matter what the geography is.
वृंदा जी, shall we start? वृंदा जी की तरफ से थम्स अप आ गया है, तो आज का सेशन हम शुरू करते हैं दोस्तों. नमस्ते, मैं पारुल. स्वागत है आप सबका हमारे आज के डाउन सिंड्रोम फेडरेशन ऑफ इंडिया के सेशन में. कई बार हम कुछ ऐसे मेडिकल इश्यूज पे आपके लिए अपने गेस्ट को लेके आते हैं जिससे आपको कुछ ऐसी सुविधाएं मिल सकें, ऐसी जानकारियां मिल सकें जिससे आप अपने बच्चों के लिए और अपनी सेहत के लिए भी बहुत कुछ ऐसा कर सकें, जान सकें, जिससे हम आगे बढ़ सकें. गैस की सीटी बहुत परेशान कर रही थी, तो मुझे वो बंद ही करनी पड़ी दोस्तों. तो कई बार कोई डॉक्टर, जब बहुत घुटनों में दर्द होता है, कोई डॉक्टर कहता है मैं हूं ना, तो हमें बहुत अच्छा लगता है. असुरा प्लीज यार काम करने दो. तो कई बार असुरा भी, असुरा का आजकल आज तक कोई इलाज नहीं है, ये ऐसे ही हमेशा परेशान करती रहेगी हमें. तो दोस्तों, कई बार हम ऐसे डॉक्टर से मिलना चाहते हैं जो ये कहे कि मैं हूं ना, और जब हमें घुटनों में और हड्डियों में दर्द होता है, तब हम खासकर इन सब चीज़ों की तरफ बढ़ते हैं. लेकिन सबसे ज़्यादा बात तब आती है कि असल में वो दर्द घुटनों का या हड्डियों का होता ही नहीं है, बात कुछ और होती है. तो आज उन्हीं गहरी बातों की तरफ आपको ले जाना चाहते हैं. आज कुछ खास जानकारियां हैं, पेन और पेपर लेकर बैठिएगा. आज के हमारे जो गेस्ट हैं डॉक्टर अजीत कुमार सुरीन, वो एक रूमेटोलॉजिस्ट हैं, इम्यूनोलॉजिस्ट हैं. तो इम्यूनिटी का एंड रूमेटोलॉजी का क्या संबंध है हमारी मसल्स, हमारे बोन्स, हमारे स्केलेटल से, और किस तरीके से डाउन सिंड्रोम ब्लेस्ड बच्चों के साथ हम बचपन से ही उनका ध्यान रखें, इस सब में आगे बढ़ सकते हैं, बहुत कुछ उनका केयर कर सकते हैं. तो आप सबकी तरह मैं भी उत्सुक हूँ. आइए मिलते हैं आज के हमारे गेस्ट डॉक्टर अजीत से, और उनसे विधिवत रूप से आपको मिलवाने के लिए आ रही हैं सैमी. सैमी, आपका स्वागत है, और हमें मिलवाइए हमारे आज के गेस्ट से.
Thank you so much, Parul. Good evening, everyone, and welcome in today's session. Yes, persons with Down syndrome frequently face musculoskeletal issues caused by low muscle tone, hypertonia, or loose ligaments, ligamentous laxity. These happen to be one of the causes in the delayed acquisition of motor milestones also. So to discuss and expand our understanding about the musculoskeletal aspects of Down syndrome is important so that we know the importance of early diagnosis, follow-ups, and right intervention. Because multidisciplinary team intervention really helps our champs to not only attain their milestones on time, but also in leading a fulfilling life. So today, as Parvul mentioned, we have with us a very seasoned and highly accomplished doctor, Dr. Ajit Surin ji. He is an expert from a top multi-specialty hospital of India in Bhubaneswar. Sir is associated with multiple caregiving organizations where experience and compassionate treatment coexist in clinical immunology and rheumatology. With over 20 years of expertise, Dr. Ajit Surin, a seasoned senior consultant, is in charge in many facilities which are committed to treating and diagnosing rheumatic and autoimmune diseases and disorders with care and accuracy. Dr. Ajit Surin possesses a vast amount of skill and experience, supported by his MD in medicine and specialized training from CMC Vellore via postdoctoral fellowship in clinical immunology and rheumatology. Further improving his skills and making him a reliable figure in the caregiving sector, he's connected with many well-known hospitals. Dr. Surin is committed to promoting the field by engaging both in research and education alongside his clinical practice. He engages actively in medical conferences and publications and advocates for lifestyle management, and also provides mentorship to both medical students and professionals. A very warm welcome to you on this platform, sir. Our parents are waiting to hear you and get enriched by your experience and knowledge. And we really want to know about the issues our champs can face in their lives and the supportive measures that what supportive measures are available for children with Down syndrome to address those. Over to you, sir.
Thank you so much, Sami madam, and thank you, Parul madam also. Sorry, are you able to hear me? Sorry.
Yes, sir.
Actually, when I was told to present on this on Down syndrome related arthritis, I have no experiential knowledge on this thing, so I had to go to a kind of net and see and find out datas and search datas, and I've come with some of them. Hopefully I'll do a justice to all who are listening to me today.
Okay.
And shall I share my thing again?
Yes, sir, please.
Yeah. Is the screen visible now?
Absolutely, sir. We can see it.
Okay, great. So just a thing. One second. Yeah. So I just wanted to know whether the parents of these children have joined.
Yes, sir. We
Okay,
have many
good.
parents joined with us from
Okay.
different parts of India. Yeah, sir.
Okay, okay. So I would congratulate them that they are a part of this journey, and I would congratulate the society for having completed 40 years, and whoever on the board, I would like to thank them for giving me this platform. Once again, I'll start it little apologetically. I have no experience as such in treating patients of Down syndrome, but I have experience in treating patients of juvenile arthritis of very young age group, and so I'll be telling from my experiences, and some of them are from the literature that was found in the books and in the net. So when we think of Down syndrome, as many of you know, it's a genetic disease, and the most common causes are meiotic non-dysfunction. There's a translocation. There's a partial trisomy. I know many would be little jargons for many of the people, but I would just try to just brush up on the deeper things. So the most common trisomy, that is most common type of Down syndrome, is the trisomy 21, which we come across many of the children. And as per literature, 12.6 per 10,000 live births in US have this genetic genomic disorder and have this intellectual disability. So I will not go into detail of it. Like I told, 12.6 in every 10,000 US birth have this problem. And the higher reported incidence has been found in Ireland. That is one in every 547 people have this disease. And like I told, most of the patients who have the Down syndrome are of the subtype trisomy 21, almost 95%. Trisomy 21 non-disjunction type of Down syndrome. So what are the common types of musculoskeletal issues that we see in these patients? So, and the other issues also. The common comorbidities are obstetric sleep apnea. They can have congenital heart diseases. They can have atlanto-axial instability. They can have hypotonia. They can have hypothyroidism. They can have epilepsy. They can have other hematological disorders, recurrent infections. And there's a arthritis related to Down syndrome, which is called Down syndrome associated arthritis, that is called DA in short form, which was coined in 1984, and that was first time described in 1984. So there are always has been a delay in recognizing these conditions because of the patient factor and the factors coming from the parents also. So there's a limited data as to say uh, when we come to DA, that is Down syndrome associated arthritis. So what is the common clinical presentation in DA, that is Down syndrome arthritis? The most common subtype is polyarticular, that is multiple joint involvement. When then four and more than five joints are involved, and there have been more than 115 has been reported out of the all the joint diseases that the Down syndrome patients have filled according to this literature. And the second most common is the oligoarticular, that is less than three joints that are involved. So over the time, 70% they progress to polyarticular. So polyarticular is more than three joint counts, and oligoarticular is less than three joint counts. And the most important factor in them is most of the antibodies that is generally present in autoantibody in autoimmune disease or arthritis, they are generally negative. They have a morning stiffness in mostly only 50% of the patients, and they have a average onset of presentation 6 to 9 to 7.4 years, sometimes even later. And 57% of the patients are females. And like I told, most of the tests are generally negative for any autoantibodies. And unlike the female presentation, that is much more higher in general population who present with arthritis. So there are a wide range of proposed mechanisms. I won't go in deep into it because I know the doctors are not here. I'm to say, but I'll just mention the names. Maybe some will be familiar with that. So there's a chronic activation of this interferon signaling. There's an altered innate and the adaptive immunity. There's a dysregulated T cell function, and subsequently there is a increased pro-inflammatory cytokine environment, which leads to this immune tolerance and arthritis. So all these conditions, they can lead a patient to have autoimmune thyroid disease. They can have celiac disease. They can have type 1 diabetes, they can have alopecia and other inflammatory arthritis. But what I understood from all this literature is that the aggressiveness of disease in patients of Down syndrome is much less when compared to the normal population. So this is a small table that shows the difference between DA, that is Down syndrome associated arthritis, and a classical rheumatoid arthritis. So if you see the pattern, it's mostly it's polyarticular in Down syndrome, whereas in rheumatoid arthritis it is symmetrical inflammatory polyarthritis. And like I told, most of these tests, rheumatoid factor, anti-CCP, ANA tests, all these tests are usually negative in DA, that is Down syndrome associated arthritis. And a few times the disease can be aggressive, there can be structural damage, and the evidence and the literature is very has we have a paucity in literature, and most of the treatment is adapted from the treatment for arthritis, like we have treated GIA or rheumatoid arthritis treatment. The prevalence also is little high in DA when compared to juvenile idiopathic arthritis. Like I told, it's mostly polyarticular. The sex predilection is equal in DA, whereas in GIA, it is the female preponderance is much higher, and other things I have already described. Sometimes we get to see some extra-articular manifestations like eye involvement in the form of uveitis, and a few times the inflammatory markers, that is the ESR and the CRPs, are high. So there is definitely the immunity comes into play when patients of Down syndrome have this arthritis. So there is a immune dysregulation, which leads to pro-inflammatory cytokine and this whole cascade, and subsequently leading to inflammatory conditions of arthritis and joint involvement. So why musculoskeletal problems are important in Down syndrome? Because and what is the cause for that? So these special children have a generalized hypotonia. They have a ligamentous laxity. The ligaments are lax. They have a joint. Their joints are also lax. We call it hypermobility joints, hypermobile joints. They have a reduced muscle strength. They have a overall delayed or gross motor development. They have altered posture and gait. They have reduced balance and postural control. There is instability in the gait and in the joint instability because of the joint instability, and there is progressive degenerative joint problems with age, and subsequently they have a little bit increased risk of susceptibility to these inflammatory and autoimmune disorders. So if you see to the right, what I described earlier was the Down syndrome associated arthritis, which is a systemic presentation, but there are certain presentations which occur area wise. So if you see the spine, there could be some children could have this atlantoaxial instability, atlanto-occipital instability, scoliosis, spondylosis, and spondylosis. So I'll just people won't understand, so I've gotten some pictures. So there is a this is spine that we see. There's a cervical spine, and the upper cervical spine, it is connected to the skull, and that is quite fixed in a way. But when these ligaments, they become little lax, they tend to have a increased movement, that is called atlantoaxial instability, and that can cause some nerve to be compressed, some of the arteries to be compressed. So that is a dangerous condition, and sometimes that requires a surgical intervention. And scoliosis, many would be aware of. So this is a curve that occurs in the spine of the vertebrae in the back. So they have many times they can do their activities of daily living, but a few times surgery is actually required. So there are other conditions that is associated with the hip problems, hip instability and dislocation, slipped capital femoral epiphysis, that is called Perthes disease, and there could be problem in the knees, that is a patellofemoral instability, and there could be problem in the foot, pes planus, that is called the flat foot, hallux valgus, or CTEV, that is congenital talipes equinivarus. So we'll go to the pictures of it. So this is a common flat foot that even common people come across. So the arch that is present in the medial side, that is lost, because of which they have pain. And this is the prominence of the medial side of the thumb, in the base of the thumb. It is also called bunion. So sometimes that requires a correction. A very few times these conditions require surgery. So this is the CTV, and many children, they are born with this kind of legs, and there's a inward curving of the legs. So most of the time it is generally treated with a proper footwear. A few times surgery is required. So what are the clinical presentations that the children present with when they come with these problems? They have persistent joint swelling. They can have morning stiffness. They can have pain during movement. They have a reduced range of motion. They can have warmth or joint tenderness. They can have flexion contractures. They can have limited hand functions. Their walking pattern, the gait would change. They could limp, and there could be an overall reduced willingness to participate in activities. So sometimes we have to look for certain things and know that they could be this arthritis that is setting in the life of these patients, in the body of these patients. So they could stop climbing stairs. They avoid walking. They refuse certain activities. They use hands less frequently. They become slower while doing the work, and they require assistance. They sometimes become irritable. And many times this arthritis is missed often because of the, like I earlier described, because of the patient factor. They communicate little less, or they have a communication difficulty. They have an altered expression of pain. They have an intellectual disability, and they have a basal hypotonia. That's madam was also telling, and they have a already a pre-existing gait, which may not, which would conceal most of the things that they already that the new things that they develop. And joint hypermobility is a common presentation commonly seen among the Down syndrome patients. And what are the clinical factors? So some of the things may be very subtle, and we have to really find out by examining. And most of the time, like I told, the inflammatory markers are quite normal. A few times it is high, and the autoantibodies that we test generally for the diagnosis of arthritis are negative. So not every painful joint is arthritis. So one has to understand this. So this portion, that is a mechanical orthopedics, and this portion I have already described and I've told. And the first part also I have already described. But there could be certain conditions where they have this hypermobility, and there could be some conditions where they can have a cervical cord compression. Like I already told, they can have an atlantoaxial instability, and that might require an intervention, that might require some support and a neurological neurosurgery intervention. So we have to look into all these things, but then that is very, very rare. And some of the common things which is also there present among the normal population: vitamin D deficiency, osteoporosis, and hypothyroidism, celiac disease, they can be also these can be also present in these patients, and we have to identify and treat accordingly. Osteoporosis is a problem which generally occurs in women who are more than 50 years of age or postmenopausal, but this occurs in these children because of being less mobile. That is, when they have quite bedridden sometimes, or when they are not moving much. That could be the reason for the osteoporosis setting in these patients. So these are the diagnostic approach when we suspect an inflammatory arthritis. This is all things that the doctor do. They see for all these symptoms of inflammatory arthritis. They assess the joints. Then they go for this further investigations. I'm just brushing up because these are the doctor has to do. So sometimes the role of imaging, the role of X-rays come into play when we cannot make out from outside and we see of very subtle changes. So generally an X-ray tells of a joint space narrowing. If there is a erosive disease that can be picked up, subluxation and long-standing structural damage can be picked up. But many times there are things which, for especially people, for patients who have a very early disease, an ultrasound and an MRI is important to actually see the signs of inflammatory arthritis, like joint effusion or any synovial hypertrophy can be found out and picked up in these ultrasound and MRI imaging. So I'll not go into very detail of the management, but most of the Down syndrome patients who have this DA, that is Down syndrome associated arthritis, they are generally treated like any other arthritis, and most of them they respond to NSAIDs, that is non-steroidal anti-inflammatory drug, or a small dose of steroid. Sometimes, if the joint is just monoarticular, that is one joint is involved, we can also think of giving intraarticular glucocorticoid or a steroid. A few times, the conventional DMARD, that is disease modifying anti-rheumatic drugs, are used for these patients, but generally they don't tolerate. And very few patients who have a very aggressive disease, the newer type of medication, that is the Balgeric therapy, can be considered in these patients. So I'll not go into detail, the same thing. But medication challenge has been seen and has been recorded in literature for patients who have DA, that is Down syndrome associated arthritis. So many patients, they don't tolerate this Balgical therapy or the methotrexate when they have aggressive arthritis. So it is a challenge actually to treat the patients of DA patients, right? So this is a table that has come from American Academy of Pediatrics. So many would be aware of that, but what one needs to see during the milestone of a development of a child. So when a child is newborn, less than 1 month, so they may have needs to see this clinical manifestation and developmental progress of eye functioning, feeding, hearing ability, and they need to connect to the supports group, coping methods. Then again, from infancy, that is 1 month to 1 year, the screening tests should be conducted for hearing, vision, thyroid function, and which has to be done annually thereafter. And growth and development has to be monitored. And early childhood, that is 1 to 5 years, physical, occupational, speech therapy has to be, if required, needs to be seeked, and the diet and the exercise regime has to be monitored. And the late childhood, that is after 5 years, the physical and sexual development has to be monitored. So generally, I don't go into all these details, but if you go into the right side of it, see the most of these patients of DA, that is Down syndrome associated arthritis patients, they have adverse effects when compared to the normal population. And biological ineffectiveness, even the newer types of treatment has been seen to be ineffective when compared to the normal patients. In DA patients, more ineffective. And more than 50% of the patients, they have discontinued methotrexate because of the intolerant issue. They cannot tolerate the medication. So I would say that the most of the treatment should be based on just minimal medication and non-pharmacological treatment. So that could be mostly physiotherapy. It could be a local compression or a movement-based intervention or positioning, and there could be improvement in the mobility, improving functional range of motions while protecting hypermobile joints from further instability. So there are certain set of exercises that the physiotherapists teach, so that they have a muscle toned exercise, they learn muscle tone exercise and joint protection exercises which the physiotherapist and the occupational therapist teach from childhood. And the long term definitely would be integration of both the medications as well as the physiotherapy and some anti-falling measures for these patients. This is just a summary of the things that I've told already, and this physiotherapists, they find a difficulty in handling these patients because of the patient factor, basically mostly, and they have a delayed developmental milestone. They have an impaired balance. They have a decreased strength. They have reduced levels of physical activity. They have sensory deficit, and they have a reduced mental and emotional well-being. So overall, if when we talk of physiotherapy, there's an active physiotherapy and there's a passive physiotherapy. So most of these children, they would require an active physiotherapy where the physiotherapist would be besides the patient to make him do all the exercises. And a team work is definitely required for these special kind of patients. Again, the major goal for all these physiotherapists is to restore and protect the function. So maintain joint range of motion, improve muscle strength, improve balance, improve gait, reduce secondary deconditioning, maintain functional independence, improve endurance, prevent contractures, improve confidence with movement. So these are all integrated within this physiotherapy. And there's another group of caregivers called occupational therapists. They have a very important role while treating for the hand function. And as we all know, as all of us know, that there's a special for the special children, they have a learning differences, but I would say they are capable of learning. They benefit from frequent repetitions, and they learn little late, but they do learn. They need more frequent practices in order to maintain a learned skill. They needed extended time to respond and have a more limited repertoire of response. So they need more time, but they definitely learn. They are capable of learning. So one need to have patience to teach them, to be with them, and to be with them while they are doing the thing. So these are the various kinds of programs that the physiotherapist generally plan: the range of motion, the strength, the balance, and the proprioception. The proprioception includes supported single length tasks and other exercises that they teach, and other aerobic exercises and functional exercises. Right. So definitely this is not so easy until unless the caregiver is a very committed caregiver and he has a passion to do that. He has a burden to do that. It's difficult for normal people to actually look after the children. So there are some evidences, some literature on effects of therapeutic exercise on motor functions of these patients of Down syndrome. But overall, the evidence remains low. Evidence remains low and low to moderate. So definitely, but this is just one literature. But definitely, I'll say that the outcome of physiotherapy and the outcome of occupational therapy and assisted therapy would be the outcome would be much better, and I think it is very important for these special kind of patients. And definitely arthritis and mental health goes side by side, and most of these patients, when we know that they have a mental issues, they have some retardation in understanding and mental retardation, they definitely benefit from physical exercises. So this chronic pain and disability, they lead to reduced social participation. They are more dependent. They have sleep issues. They have fear of movement. They have lack of confidence. They're irritable. They have depressive symptoms also. They lack confidence. So definitely, this physical therapy is very important even for the mental development. Conversely, depression or anxiety can reduce physical activity. They can uh, reduce the exercise adherence. They can reduce the rehabilitation participation and the pain coping and social engagement. So it is a cycle. It's a vicious cycle. So these two have to be actually looked on, the mental health as well as the physical health. So sometimes we think that the new behavior or the change in behavior is a psychiatric disorder. It is not actually. So there could be some other issues associated with those things. We have to look into the thing by talking to the patient, talking to the people, and know and address that issue. Some of them, some of the exercises and the physiotherapies can be tailored, and we can put them into some tailored exercise protocols. These low impact aquatics are very important. Patients uh, which reduce the burden on the joints, and that is helpful in the cardiovascular fitness also and muscle strengthening. And the cycling and resistance, they are also very helpful, where they build in the hip and the knee stability without high impact stress on the inflamed joints, and stabilization training, that is very important sometimes, and the balance boards and the coordination drills, which helps in the proprioception of these patients. So this is something which is extrapolated from patients who had rheumatoid arthritis. This is called SARA, strengthening and stretching for of rheumatoid arthritis of the hands. So most of the things are to see the fine motor functions of the hands. So mostly it is done by the occupational therapist to improve the hand functions, improve the uh, hand functions, joint mobility, and activities of daily living. So this is important, and this is generally this group of physiotherapists called occupational therapists, they are involved in it. So motor learning considerations, they reduce uh, hands-on support when they reduce hands-on support when safe, so that they can avoid dependence. They practice new skills in the new environment and provide visual and tactile cues. So these would be generally helpful for patients to improve their motor skills and even the mental skills. So this is a special uh, therapy called sensory integration therapy, wherein all the five senses, they are taken into consideration to these five senses are developed, and it is very important for patients who have DA as well as Down syndrome. So the key points are musculoskeletal problems should not be overlooked in Down syndrome. And among all the issues, Down syndrome associated arthritis is under-recognized. It's the most common. And generally, I would say that overall, they don't have a very aggressive disease. They have a very low-grade inflammatory arthritis, and that can be actually treated. It should be treated multidisciplinary way. And mental health, pain, disability should be managed together. Like I told you, the multidisciplinary approach is the best approach, and individualized care for every patient. Thank you. Thank you so much.
बहुत बहुत शुक्रिया डॉक्टर अजीत, बहुत अच्छे से आपने सारी चीज़ों को हमें समझाया है, और मुझे लगता है हमारे पेरेंट्स को काफ़ी इससे हेल्प मिली होगी। और डॉक्टर अजीत से आप जो भी अपने सवाल पूछना चाहते हैं, आप चैट बॉक्स में पूछ सकते हैं, या आप अपना अनम्यूट करके और यहाँ रूबरू भी उनसे सवाल पूछ सकते हैं। मुझे लगता है कि ये अच्छी बात है, जैसा कि डॉक्टर ने बताया कि इतने कोई मेजर इश्यूज नहीं होते हैं आर्थराइटिस के अलग से डाउन सिंड्रोम बच्चों में, तो हमारे लिए ये राहत की बात है, और जो है वो क्योरेबल है। जब तक हमारे दोस्त आपसे कोई सवाल पूछते हैं, डॉक्टर अजीत, मैं एक सवाल आपसे पूछना चाहती हूँ कि रूमेटोलॉजिस्ट मोस्टली बदनाम होते हैं अपनी दवाइयों की वजह से। उनकी बातें तो हमें बड़ी अच्छी लगती हैं जब वो कहते हैं कि अच्छा ये वाली आपकी बात का ये क्योर है, ये कारण है। जब वो कारण बताते हैं तो बड़ा अच्छा लगता है कि हाँ किसी ने हमारे दिल की बात समझ ली है, हमें क्या प्रॉब्लम है, ये इसकी जड़ तक वो पहुंच गए हैं। लेकिन जब आप दवाइयां खिलाते हैं तो हालत खराब हो जाती है। तो उस बारे में आप क्या कहना चाहेंगे?
मैडम, जैसा जैसा डिजीज है ना, वैसी ही मेडिसिन भी है।
जी।
अब ऐसा बीमारी है जिसमें डिफॉर्मिटी हो जाता है, हाथ वगैरह टेढ़ा हो जाता है, तो उसके लिए कड़ा दवाई ही हम लोग काम करेगा। वो तो देखिए, हम लोग जो भी दवाई देते हैं ये सब एविडेंस बेस्ड मेडिसिन के ऊपर बेस्ड है। आई मीन सब कुछ अप्रूव्ड है मेडिसिन। अब जहाँ छोटा मेडिसिन से काम हो जाता है तो वहाँ छोटा मेडिसिन देते हैं। जहाँ छोटा मेडिसिन से काम नहीं होता तो हम लोग को मेडिसिन बढ़ाना होता है। और फिर बायोलॉजिकल थेरेपी भी दिया जाता है, जो कि बहुत एक्सपेंसिव है। और
हम्म।
ये सब तो एक्सपेंसिव है, मगर ओवर द इयर्स या अभी उनके कॉस्ट वगैरह कम हो गए हैं अभी। और डेफिनेटली
हम्म।
जैसा डिजीज बिहेव करेगा वैसे ही ट्रीटमेंट करना है। और हम लोग कई बार हम ये सोचते हैं कि आर्थराइटिस ये है ना कि जॉइंट का प्रॉब्लम है, ये जॉइंट्स में सिर्फ है। मगर ऐसा नहीं होता है। ये फेफड़े को भी इन्वॉल्व कर सकता है, हार्ट को इन्वॉल्व कर सकता है, आंख को इन्वॉल्व कर सकता है, किडनीज को इन्वॉल्व। तो जब मेजर ऑर्गन इन्वॉल्व होता है तो हम लोग को उस तरह से कड़ा दवाई देना पड़ता है काफी। ये काफी
ज्यादा ज्यादातर इसमें ऑटो इम्यून डिजीज रहते हैं, तो ऑटो इम्यून डिजीज का स्ट्रेस से कितना संबंध होता है, ये और मैं आपसे जानना
ये
चाहूंगी।
बहुत इंपॉर्टेंट है मैडम, क्योंकि जब हमारे शरीर में इन्फ्लेमेशन चल ही रहा है, जब एक इन्फ्लेमेटरी प्रोसेस चल ही होता है, चल रहा ही होता है, तो स्ट्रेस तो आता ही आता है। हाँ। और एक ऐसा नहीं है कि आज मैं दवाई दिया और एक हफ्ते के बाद वो ठीक हो जाएगा, ऐसा नहीं होता है। ये लंबे समय का बीमारी है। तो उनको मेरे क्लिनिक में या फिर मेरे हॉस्पिटल में जब भी ये पेशेंट आते हैं, तो मेरे पास एक पेशेंट एजुकेशन प्रोग्राम, पेशेंट एजुकेशन देने के लिए एक लड़की रहती थी जो कि सिखाती थी, और हम लोग हमेशा एक बुकलेट्स देते हैं। तो मैं समझता हूँ कि उनको ना अच्छे से समझाने से वो समझेंगे। और कई बार हम लोग जब उनको समझाते नहीं है तो वो सोचते हैं, होपफुल रहते हैं कि ये कभी ना कभी ठीक हो जाएगा। ये तो छोटे कम दिन का बात नहीं, ये तो लंबे समय का बात है। तो हम लोग को उनको समझाना होता है कि ये बीमारी एक लंबा बीमारी है, जैसे टाइप 1 डायबिटीज मेलाइटिस, ये एक भी ऑटोइम्यून डिजीज है। ये हमेशा दवाई चल रहा है उसके लिए। तो वैसे ही ये डिजीज का भी लंबा चलना है। मगर कई बार जब पेशेंट परसिस्टेंट होता है, उसका ट्रीटमेंट बराबर लेते हैं, तो उनका आउटकम बहुत अच्छा होता है। तो उनको ही इंकरेजमेंट मिलता है कि हाँ मेरा बीमारी अच्छा हो रहा है। डेफिनेटली लॉन्ग टर्म ट्रीटमेंट होता है, मॉनिटरिंग का जरूरत होता है, मॉनिटरिंग डिजीज के लिए भी और वो मेडिसिन के साइड इफेक्ट्स के लिए भी। तो सब चीज का है, और फिजियोथेरेपी का बहुत इंपॉर्टेंट रोल है, और काउंसलिंग का भी बहुत इंपॉर्टेंट रोल है।
तो क्या इस तरह ऑटो इम्यून डिजीजेज से अगर हमें प्रिकॉशन लेना है तो क्या एक प्रिकॉशन ये भी है कि हम स्ट्रेस फ्री लाइफ रखें अपनी?
एकदम एकदम मैडम, एकदम। अगर मैं बोलूं कि एक पेशेंट है जिनको कि आर्थराइटिस है, और एक जो कोई काफी स्ट्रेस है उसके उसमें, और एक पेशेंट है जिनको आर्थराइटिस जिनमें स्ट्रेस कम है, तो कम स्ट्रेस वाला पेशेंट जरूर जल्दी अच्छा हो जाएगा।
इसमें क्या प्लेसेबो इफेक्ट भी काम करता है डॉक्टर?
हाँ, डेफिनेटली डेफिनेटली मैडम। देखिए, एक बड़ा डॉक्टर अगर कोई है, जैसे कि अपोलो दिल्ली, आप कहाँ पे हैं मैडम, कौन से जगह में?
जी मैं नोएडा।
नोएडा। तो दिल्ली में कोई डॉक्टर है, अगर सपोज अपोलो हॉस्पिटल जाए कोई बंदा, बोले कि वो डॉक्टर बोले कि मैं सबसे बेस्ट मेडिसिन तुमको दे रहा हूँ, तो अगर वो अच्छा होगा या ना होगा, वो तो अच्छा ही काम करेगा जब बड़े डॉक्टर बोले हैं। और उनको भी लगे उन, और एक चीज है कि उनको पेशेंट को भी डॉक्टर के ऊपर विश्वास है कि हाँ मेरे को बहुत अच्छे डॉक्टर मेडिसिन दिए हैं। अब उसमें कुछ है ही ना ही होगा, मल्टीविटामिन नहीं होगा, मगर वो काम करना चालू करेगा। वो तो अंदर की बात है, वो तो विश्वास की बात है, वो तो होता ही है।
मुझे इसमें बड़ा
प्लेसिबो इफेक्ट
इंटरेस्ट
होता है।
आता है इसलिए मैंने आपसे पूछा। समीक्षा, हमारे दोस्तों से हम एक बार फिर से गुजारिश करेंगे कि जिनका भी कोई सवाल हो वो यहाँ पूछ सकते हैं। और डॉक्टर की इस बात से समीक्षा मुझे एक शेर याद आ रहा है कि मैं
बिल्कुल।
खुदा का नाम लेकर पी रहा हूँ दोस्तों, जहर भी इसमें अगर होगा दवा बन जाएगा।
Absolutely, Parul. And thank you so much, sir. As they know that, knowledge is when you find the root cause of a problem, so the treatment and, progress or the improvement become easier. So yes, thank you so much for giving us few nice steps to understand and classifying the musculoskeletal issues by body, the spine, the hip, and the foot, and the like. So it makes it easier to understand them and also to be alert and observant when something occurs. So here is a parent wanted some English translation of your response when you mentioned about RA and ANA and other key factors. When you were talking to Parul, we do have audience from a non-Hindi speaking states also, sir. So if you can
Yeah,
quickly share in English also so that
ये रूमेटोड आर्थराइटिस जो है, ये
yeah,
एक्चुअली ये गठिया बीमारी है
yeah,
जिसमें हाथ का इन्वॉल्वमेंट होता है, हैंड्स
yes.
का
You
इन्वॉल्वमेंट.
need to speak in English for this
You want to
particular
get
response. Yes, sir. Sir, the
you want
English
in
of the
English, is
audience.
it?
Yes, sir.
Yes.
Yes, sir.
Okay.
Yeah.
So this is the inflammatory joint inflammation and deforming disease, which generally involves the hands. So most of the time it starts with the hands, and especially the small joints of the hands and the wrist. So if that inflammation is not stopped, it is not treated in time, it is not diagnosed in time, it keeps on going. The ongoing process actually leads to deformity and leads to decrease activities of daily living, decrease in functional life. So all those things are there.
Yeah.
So one needs to get diagnosed early, initiate the treatment early, and so that the inflammation becomes less and the activities of daily living becomes better, and the functional life also becomes better. So
Yeah.
one, it's very important to diagnose, pick up early,
Mm.
pinpoint the diagnosis and start the treatment.
Mm. So, sir, he says that his mother has osteoarthritis, and he himself, at 60 years, her mother, and 42, he himself has RA. So, will I have to follow cautiously for his son? He's asking. He's 7 years with Down syndrome.
Not really, not really. When some of the patients, when they ask us, how much is the chance, if I am a patient of arthritis, how much is the chance of my child or my son or daughter having arthritis? So to explain them, to make them understand, we tell whatever the chance of arthritis, there's a chance of incidence of arthritis in a normal population is there. It is little higher than that. So we don't have to do any tests until unless there are symptoms. So what happens is, suppose we test them, suppose a test comes positive, they'll always have this fear that sometime they'll develop this disease. That is one thing. So there's nothing that we have to do until as there are symptoms of it. Okay.
Actually, he was wanting to know that is there any genetic pattern about it or something?
Yeah, genetic pattern is there. Genetic pattern is there. So in my 25 years of experience, I would say that a very few families, they have this family pattern of involvement. I mean, more than 3 or 4 members have this arthritis or this autoimmune diseases. So generally it is very rare. So there is a family of maybe 5 sisters. One has autoimmune disease and 4 don't have. So it's not necessary. So there is a genetic predisposition for the disease, but there are other factors also that comes into play and leads to the disease. So we have understood certain things and we have not understood many of the things. So definitely lifestyle and food habits and the smoking, drinking, all those things are actually leads to, and sometimes it triggers the disease when these people have the this genetic predisposition of having the disease.
Sir, another question comes. It says that सर मेरी बेटी 9 साल की है, उसको हेलिक्स वेगस है. अभी मैं फिजियोथेरेपी के सजेशन से जॉइंट सेपरेटर्स यूज कर रही हूँ. क्या मुझे किसी एक्सपर्ट से मिलना चाहिए फॉर फर्दर डायग्नोसिस और अंडरस्टैंडिंग?
अगर अगर ये प्रॉब्लम है और वो चल पा रही है, अच्छे से अपना काम कर पा रही है, तो मेरे को नहीं लगता कि किसी के पास जाना है, कहीं जाना है. मगर अगर उनमें उनको चलने में तकलीफ हो रहा है, कांस्टेंट पेन हो रहा है, तो डेफिनेटली कुछ हो सकता है कि फुटवेयर से हेल्प हो सकता है या कुछ प्रोस्थेसिस से हेल्प हो सकता है. और उसके बावजूद अगर वो कम नहीं हो रहा है, तो हो सकता है कुछ करेक्टिव सर्जरी से हेल्प हो सकता है. मगर ऐसा टाइप का करेक्टिव सर्जरीज बहुत कम जगह में होते हैं इंडिया में. एक है जो कि एक कोयम्बटूर में है, एक है जो वेलोर में है, और कहीं पर दिल्ली में भी है शायद. तो ये सब कहीं कहीं पर है जो ये स्पेशल सर्जरीज, करेक्टिव सर्जरीज कर सकते हैं. कभी कभी ऐसा भी होता है कि अब सर्जरी ठीक से नहीं हुआ, फिर लेने का देना हो गया, बहुत और कॉम्प्लिकेशन बढ़ गया, तो वो भी होता है. तो
Yeah.
हमारी जरूरत है कि नहीं वो फर्स्ट एसेस करना है, और जरूरत है तो सही जगह में जाके सर्जरी कराना चाहिए।
Yeah. Jitisha, I hope Jitita's mom it is. I hope you got the answer. आपको कुछ आगे ऐड करना है, पूछना है तो अनम्यूट कीजिएगा. Yeah, so we'll move on to the next question. It says, my 19-year-old son was walking and running before, but now for the past year, he's walking with catching his hands. Physiotherapy is on. Neurologist said it is muscle stiffness and prescribed baclofen, which he is taking for the past 6 months. Not seeing much improvement yet. Is there any other medical medicine for muscle stiffness? So,
No, baclofen is a good medicine indeed, but we really have to see whether it is a localized kind of thing or it is a systemic, it's a back thing, it's a generalized thing. So all these things have to be seen. So, like I was telling, it's a multidisciplinary thing. First thing is we have to point out the diagnosis, whether it is actually related to a muscle stiffening thing or it's a bone or a joint problem. So all these things have to be really seen, and then go ahead with the physiotherapy. And many times when actually this is a teamwork that has to be done. This is a multidisciplinary thing that has to be that should handle this kind of patients. So once the doctor pinpoints the thing, then he can actually have a word with the physiotherapist, and accordingly the physiotherapist would give his therapy or whatever.
yeah. Sheila, you need to work closely with your physiotherapist and the doctor. Yeah.
Yes.
So, any other question
There was
among
a
our
picture
audiences?
that one of our parents wanted to share, sir. I will share that picture now.
Okay.
One.
Please, Brinda, please.
Yeah, I will just share that picture, sir. So if you can just see. Yeah. So Surekha, ma'am, I think you are here. Maybe you could ask the question once sir sees this picture. Sir, you've seen the picture, right?
Yes.
Surekha, ma'am, please
So
unmute.
Good evening, sir.
yes. Good.
Sir, she is my daughter. She's 14 years old with Down syndrome. सर इसके लेग में आप जैसे देख पा रहे हैं तो ये वन लेग तो स्ट्रेट रखती है बट दूसरा जो लेग है उसको नी को लॉक कर लेती है तो उसमें इसको बैलेंस वगैरह प्रॉपर नहीं हो पाता है और ये योगा भी बहुत अच्छा करती है लेकिन योगा में जो इसके कुछ ऐसे पोजेस होते हैं जिसमें लेग्स स्ट्रेट करना है तो वो स्ट्रेट में उसको पेन आता है नी में तो इसके लिए मुझे क्या करना चाहिए सर?
मैडम इसमें एक आप कंसल्ट कर सकते हैं ऑर्थोपेडिशियन को, और कई बार हम लोग को नी सपोर्ट का जरूरत होता है. देखिए उनका जो पैर है ना, जिस तरह से स्ट्रेट रहना चाहिए वो हाइपर एक्सटेंड हो जा रहा है, ठीक है, तो बेंड हो जा
जी
रहा है. तो चीज है कि उसको स्ट्रेट रखने के लिए कहीं कहीं नी सपोर्ट का जरूरत होता है, कहीं नी ब्रेसेस का जरूरत होता है. तो कौन सा सही होगा वो एक बार ऑर्थोपेडिशियन डॉक्टर से मिलने के बाद कर सकते हैं. और कई बार ये एक हाइपर मोबाइल जॉइंट्स जो बोला था, बेनाइन हाइपर मोबाइल जॉइंट सिंड्रोम, उसका पार्ट होता है. कई लोगों का वो फ्लैट फुट के साथ भी रहता है ये, तो वो सब चीज को
जी
एड्रेस करना है. कई बार फ्लैट फुट के साथ जब आते हैं तो हम लोग उनको करेक्ट फुटवेयर, जैसे कि आर्च सपोर्ट वाला जो स्लीपर्स होता है, या कभी कभी वो कहीं पर वो बनाते भी हैं शूज, वो पैर का वो मेजरमेंट्स ले करके वो फुटवेयर से ही बना करके भी देते हैं. तो वैसा सेंटर में
जी
आपको जाना पड़ेगा. फर्स्ट आप कीजिए कि आप ऑर्थोपेडिक्स डॉक्टर के पास जाइए, उनसे मिलिए, बताइए. और चूंकि वो कितने साल की, 19 ईयर्स की ना,
14 सर
14.
15
तो
ऑलमोस्ट
आप
15
अगर आपके शहर में पीडियाट्रिक ऑर्थोपेडिक्स है तो वहां चले जाइए, सबसे बेस्ट होगा पीडियाट्रिक ऑर्थोपेडिक्स. तो
ओके
हाँ, अडल्ट ऑर्थोपेडिक्स से जाना अच्छा रहेगा कि पीडियाट्रिक ऑर्थोपेडिक्स को भी चले जाएं. और ये एड्रेस ये बताइए, चीज से बताइए. और कई बार कुछ एक्सरसाइजेस भी बताएंगे जिससे कि वो और फर्दर एक्सटेंड ना हो और पीछे ना जाए वो पैर.
ओके ठीक है
तो
सर
अब मैं सोचता हूँ ये राइट एज है मैडम अभी करने के लिए, क्योंकि बाद में वो करना मुश्किल हो जाएगा. अभी करेक्ट किया जा सकता है.
एक्सरसाइजेस जो मुझे बताई हैं वो मैं रेगुलर कर भी रही हूँ बिकॉज वो योगा भी करती है तो मुझे बस उसमें ही उसको ज़्यादा प्रॉब्लम होती है बाकी वो रनिंग कर लेती है वॉकिंग स्टेयर्स वगैरह सब करना वो पूरी इंडिपेंडेंट है ड्रेस उसको होना है पहनना है पैंट्स पहनना है एवरीथिंग वन लेग पे भी वो बैलेंस ले लेती है बट जब उसका पोजेस योगा का टाइम आता है उसमें उसको आके पेन बहुत होता है
नहीं मैडम,
तो
मैं सोचता हूँ कि आप डॉक्टर के पास जाइए एक बार. वो
जी
एक बार एग्जामिन करके देख लेंगे, और कुछ चीजें हैं वो बताएंगे आपको, बेटर
सर
होगा।
मैंने एक्चुअली यहाँ जिनको किया था डॉक्टर पटवर्धन है उनको किया था, लेकिन पुणे में
अच्छा
पर मुझे उन्होंने ऐसा एक्स्ट्रा कुछ सपोर्ट के लिए बस नी कैप पहनाने के लिए बोला था, वो मैंने किया उसको, लेकिन आफ्टर नी कैप भी उसको पेन आता है तो।
हाँ, क्या है कि मैडम आज ना, अभी 14 ईयर्स की है, तो अभी पेन कम है। जैसा वो
हम्म
बढ़ेगी तो उस पर, उस
जी
नी जो है, जो बेंड ऑलरेडी है, उस पर प्रेशर ज्यादा पड़ेगा,
प्रेशर
तो
आएगा,
वो
करेक्ट सर।
उसका पेन होगा। तो अभी से वो करेक्शन करना चाहिए, अभी से वो एक्सरसाइज इंटरवेंशन थोड़ा सा एग्रेसिवली करना चाहिए अभी से ही, तो फ्यूचर में कोई सर्जरी का भी जरूरत ना पड़े।
सर मतलब पुणे में मुझे कुछ आप सजेस्ट कर सकते हैं, मतलब कहीं जाने
मैं
के
तो
लिए?
सुना सांचेती अच्छा है बोल के, मेरे को पता नहीं है, सांचेती करके है, अच्छा
संचेती में
है।
ही गई थी सर, डॉक्टर पटवर्धन वही है, संचेती में ही
वहीं
गई
पर है
थी
ना,
मैं,
हाँ।
उन्होंने।
तो वहाँ
जी
उस हॉस्पिटल में कोई पेडियाट्रिक ऑर्थोपेडिक्स है क्या? उनको दिखा सकते हैं।
पटवर्धन सर पीडियाट्रिक तो नहीं है, बट मैं सर्च करती हूँ सर।
मेरे फ्रेंड्स है पुणे में, अगर नहीं तो मैं बिना मैडम को बता सकता हूँ, कोई पता लगा करके मैं बता दूंगा आपको
Yeah,
कौन है
please,
पेडियाट्रिक ऑर्थोपेडिशियन।
that will be a
मैं
great help
बता
प्लीज
for
सकता
our
सर।
parents,
हूँ।
I
राइट,
guess. Yeah,
जी
राइट,
जी।
yeah.
थैंक यू सर,
Surika,
थैंक यू।
by any chance, are you coming for IADC 2026?
अभी तो ऐसा नहीं है, थोड़ा घर में इश्यूज थे तो ऐसा।
Okay, no worries. Otherwise, we do have our orthopedic sir who keeps coming, and he would have guided.
हम्म
Anyways, I think you
हम्म,
keep your search on. Otherwise, come back to Brinda. I think she'll be able to support in this aspect.
श्योर
Yeah,
श्योर, थैंक
so
यू सर।
thank you, sir, for so beautifully answering all the questions patiently. And
थैंक यू।
I think parents have received the correct guidance from the expert. And any other question for from anybody? Because we are moving with correct timing and dot on time. I think we are able to close the session. Yeah, so we have got one quickly. So it says, sir, my son is 6.5 years old. When he fall asleep, he suddenly wakes up and starts shaking his both hands. Seems like he having pain, and it goes after 2-3 minutes and happens for 7 to 8 times. Sir, what it could be? It happens only while he's sleeping, and he wakes up. Anything
Okay,
you would be able
yeah.
to? Yeah.
So, madam, thing is, no, whatever pain, whatever Down syndrome related arthritis that is spoken about, they are all mechanical things and mostly inflammatory things that generally doesn't occur while a person is sleeping. Okay. So if it is occurring while sleeping, I think you should go to a neurologist. So it could be a simple seizure also. We don't know. Or it could be something called restless leg syndrome. We don't know. Or it could be some of the side effects of the medication that he's taking. So it is very unlikely that it is related to arthritis. It is something related to a movement disorder. Okay. So you need to see a, what is the age of the patient? 9 years.
6.5 years, sir.
Six
साढ़े
of
छह
it.
साल.
So
Yeah.
you need, आप ना एक pediatric neurologist को कंसल्ट कीजिए.
Yeah.
हाँ, आपको दिखाना चाहिए, क्योंकि मूवमेंट डिसऑर्डर है और उसके वजह से ही इज गेटिंग अप इन द नाइट, getting up from his sleep. So you need to address that issue.
Yeah. So, Chikmat, you need to consult a
Yes,
neurologist for the same.
yes, yes. And if it's happening very frequently, then you need to go. Need to go
Yeah,
ahead.
7-8 times, I think it
Is
looks
he
like.
on any medications now?
Chikmat, is he taking any medication? If she comes,
Yeah, he's on
yeah,
hypothyroidism. He's taking
Oh,
hypothyroidism.
okay.
okay.
Yes.
Only
No,
thyroid
yes,
medication.
only no other medicines.
Okay. No, so
Okay.
you need to see a neurologist, a
Okay,
pediatric
doctor.
neurologist. Yeah. Yeah.
Okay, sir. Thank
Yeah.
you. Okay.
Yeah, I think for as of now, Parul, we have come to the last question and that has been addressed. And we really want to thank Dr. Ajit for, being with us today and telling us a lot about DS in a very systematic manner. And we are very happy that you could do so much of reading about it. And we have another doctor, who understands the diagnosis and our parents and their concern for, their child's health and improvement. Thank you so much for being with us, Dr. Ajit Surin. We look
Thank
forward
you.
to having you again with the more knowledge and more expanding of,
Sure.
interaction with us. Yes, over to you, Parul.
बिल्कुल, मैं भी बहुत शुक्रिया अदा करना चाहूँगी डॉक्टर अजीत का एक बार फिर से। बहुत ही सुंदर प्रेजेंटेशन था और मुझे लगता है हमारे वो दोस्त जो इसे बाद में भी देखेंगे यूट्यूब पर, सैमी, वो भी इससे बेनिफिट लेंगे। और अगर कोई भी डॉक्टर अजीत को कांटेक्ट करना चाहता है तो वो बृंदा जी के थ्रू कर सकता है। ओवर टू यू बृंदा जी।
Thank you so much, sir, for being here. And thank you, Sammy, and thank you, Parul, as usual. So with this, we will end the session and we look forward to having more of this. So see you all next week. Till then,
Bye.
bye. Take
Thank
care.
you.
Thank
Thank you
you.
so much. Thank you.
Thank you so much.
Thank you so much, doctor.
Thank you, ma'am. Now I'm ending the session.
Thank you, Brinda.
हम लोग पूरा वेट कर रहे हैं, कब आएगा 16 17
आ गया बस।
I'm
आगमन
so
कर
sorry.
आ गया।
So we are ending the session now.
Yes.
Bye.